So there won't be class Monday afternoon. I know it's upsetting. I'm not going to get through all of this female reproductive chapter. I've already recorded the part that I will send you because it's the same one I do for my advanced phys class, and I recorded that this morning for them, who would normally be coming in here after you, but we're not having it today. So, but I will be around all day Monday. We have Science Day over in John Jay, and we have speakers in the morning. Students are doing presentations, posters, and activities in the gym in the afternoon. So if you need me, I'll be around my office. I'll be on email. We'll be good. So if you need anything, holler for that. Happy to stop by if you have a question. Science Day is interesting depending on what you have going on in the morning. There's some nice presentations. Some of them will be similar to the ones that are going on now or have been going on now in the honors presentation. We get a lot of double duty on that. So that's number one on the hit parade. So no class, and we'll see everybody for no class on Monday, and then whenever our finals are scheduled. Yours is what? Wednesday afternoon, right? We'll be crowded here Wednesday afternoon. We have a lot of final takers from the 12 o'clock. We're going to squeeze this. We're going to be tight squeeze. Now, so I'll get to the way to point this out with regard to female repro. I'm not doing a lot of the anatomy. I'm going to review the exam that I have that you'll be taking, and whatever it is in that, how should I say it? If there's anything anatomical of anything remarkable, I will let you know. The hormones are going to be extremely important, understanding the roles of estrogen and progesterone, but the rest of the stuff to me is mostly anatomy. I mean, and I don't want to rebuild it. And I basically didn't. If anything, there was a little bit more in the male anatomy because to me the male anatomy is more complicated. Female anatomy is relatively straightforward. Okay, the hard part, the female physiology, is where we focus on because that's much more complicated. It's here. The first little part that's noteworthy is this. So understand that this is it's discontinuous. In the male, sperm they were in another area other than that self-contained duct system, and then being ejaculated out, your immune system would attack them because they're viewed as foreign. The egg is actually ovulated not directly into that tube. They're not connected. It's not a closed system. It's not going from point A to point B and it's in a tunnel of its own where nothing else can get through it. It's ovulated directly into the abdominal peritoneal cavity. Because of that, we could have ectopic pregnancies, although rare, they do occur in the abdominal pelvic cavity, okay, as opposed to in the tube, whereas typically we call it a tubal pregnancy, which is typically where an ectopic occurs. So this is discontinuous. Those little finger-like projections are called fimbriae. They have cilia on them. Mucus comes out and secretes, and the cilia create little eddies and currents that help to basically sort of cause the egg to follow those currents and get sort of sucked in, so to speak, into the tube, and then it basically gets fertilized around here about 1/3 or halfway to where it goes to the uterus. Okay, so that's worth remembering. It's there. The other part, understand, this is one of the reasons why when someone's pregnant, why they're always having to urinate, because the way that this is typically the normal position is draped over the bladder, it puts pressure on. That's there. The only time we see it tent or go vertical like that is during the arousal phase and during intercourse, because that facilitates the sperm entry, sort of giving him a direct route as opposed to having this over the top. So, I mean, it's one of those neat kind of things that occur, things that we see biologically, internally, that facilitate the actual act of fertilization that occurs. Again, my context for this is it is by no means the area where I can explain to you as much about as I would like to as other topics. It's not my long suit, so to speak. But my context is more, again, of what goes wrong as opposed to what goes right, because my knowledge base comes from my first wife and I trying for 5 years to have children, more than 5 years, to have children biologically. And why, I don't know, because my adoptive children are driving me crazy today. one in particular. But I digress. He's only 41, or he will be at the end of the month. It's driving me to drink. Thankfully, I don't drink. Moving on. But today it may be different. So there's nothing special here to talk about. Yeah, the ovary is the primary. Everything else is an accessory structure. To me, the big thing is about these ligaments. They're really not ligaments, they're folds of connective tissue that are rather firm. And obviously they're very supportive. The big deal with them is, when we look at it, and I'll flip over to it here, is this. There's a terrible condition that they'll talk about. I'm going to try to get to the slide. Oh, sooner than this. Pelvic inflammatory disease. This is, I don't know whether in your micro, my micro, we did talk about it. It's when, this is the real sad part about a variety of gonorrhea, chlamydia, trichomonas vaginalis, for instance, other pelvic and other sexually transmitted disease. In the female, they're relatively silent until such time as they become a 5-alarm fire. The name of that 5-alarm fire is PID, or pelvic inflammatory disease. Effectively, at that point, it means it has to do with the anatomy. And yes, and the end product of this is increased number of ectopic pregnancies, infertility, early hysterectomies, all terrible things. And it all has to relate to this. Once this infection goes through the uterus and gets into the tubes, we've achieved PID, or pelvic inflammatory disease. The whole area has a connective tissue that basically contains some of the whole area becomes inflamed and damaged. The pain is intense. And the only way we diagnose it initially is that internal or pelvic exam. And a lot of times it's something that doesn't have, all of a sudden, the person will be unaware and just notice vague, maybe some stomach, maybe some pain on urination. They go for an examination. The examination occurs, and all of a sudden they're palpating in here. The physician, it's like, oh my God, just a nightmare ensues. That's the tragedy for that. In my experience, a lot of times they're asymptomatic until they're full blown in the female. A lot of times in the male, they're not asymptomatic. Okay, so they're once it gets to the severe nature, then they begin to get attended to. In the female, that delay can be very, very costly. Would be the way to describe it. So I'm not going to go in crazy about cortex and medulla and all of these types of things. Not a big deal. Okay. Well, effectively, the tubes are where normally fertilization occurs. We'll call them uterine tubes, fallopian tubes, oviducts, all the same thing. Every author has a different name. There they are. They're not terribly long. They're shorter than you would think. And again, fertilization occurs not from where it starts, from where it enters the uterus, somewhere in between, usually a half to 1/3 on its journey, on the egg's journey. And again, it's being moved with those sort of currents of mucus and things like that. Not a big deal for anatomy, but the fimbriae are important to remember, those fingers, and the fact that they have cilia. Yeah, the rest of these terms I'm not too worried about for you. And this just tells you what happens to it, etc., etc. In the same illustration. So I'm trying to buzz through this. Again, ectopic is either in the peritoneal cavity or in the tube. Okay, and the trouble is not. I understand that by and large they abort, but the bleeding can be significant. But the problem is, once that occurs, if it's in a tube, now that tube doesn't work anymore. So now you're limited to one side. It doesn't preclude. A gal worked for me, and she had a tubal pregnancy, and thankfully, I mean, it was so traumatic, but frankly, by the time she relocated and left my employ, that she was pregnant again. So I mean, it just thankfully it didn't stop her from becoming pregnant. And there's the PID. Now, the uterus is basically the receptacle, if you want to think of it that way, and it's a big, strong, muscular area. Typically, it implants along the walls. So you think of it as like a dome structure. The dome portion is called the fundus, like the dome of the stomach. But typically, it implants in the walls along the side. Not. It can be anywhere, but the dome less frequently. So that's just the anatomy of it. Again, I went over chapter and verse of this in my micro class. It is awful. HPV. The numbers are staggering. These are about 8-year-old numbers for this PowerPoint sequence. Maybe the treatment now is better, but killing half. I mean, we were seeing about, according to looked at the PowerPoint and the text we are using for micro now, the number's about 80%. 80%, not killing 80%, but 80% of cervical cancer is directly related to human papilloma. It's pervasive. Most people are exposed to it. It's not it's not what we call a notifiable disease, which means it's something, it's part of us. Most people who are sexually active are going to encounter it. It's just the way it is. The current recommendation is now younger than this. That was in the textbook we're using for micro, and now it's down to like starting at 9-year-old for those who would want to choose to, not speaking very distinctly, but who would choose to have this immunization. Maybe some of you did, maybe some of you didn't. The argument has always been sort of two-edged. I mean, you're preventing a cancer which is certainly a killer. Hopefully, not, like nothing is 100% successful. That's the good news. A lot of parents and a lot of families feel that that's almost like saying this gives license to promiscuity. As I've said to all my classes, and I probably have said to you, I'll say it again. I am the wrong person to listen to. Remember, and the big problem we have in this country is we don't talk about sex. We don't talk about, we're very provincial. We're still a very young country. We don't sit around at the dinner table and our teenage children telling us about the interactions they're having with their partners, et cetera, as they do in other countries, as they do in Europe. It's out on the table. So, I mean, people, it isn't stigmatizing. Whatever your feelings are about that. But I am certainly an authority because my daughter only had her baby before she was 16. So, I mean, we were really effective in teaching. So take it with a grain of salt. But I have a lovely granddaughter, and I'm apparently going to have a great grandson in the very real near future, I'm told. So old. Don't start. Neither of you. You too. What? Yeah. Tell me about your buddy next door. Give him a hard time again. Exciting? Okay. Any prospective babysitters here? I know for the appropriate fee we can talk. So all of that. So it's very interesting. Really, I say, whoever you are, whatever your orientation is, if you're going to be sexually active, be responsibly sexually active. That's the same thing with getting checks, with getting smears. If you have new partners, I mean, it's not only is it important for you, it's important for the people you interact with, whether you're on an intimate or even a non-intimate basis. It just is. That, at least my kids were responsible in that regard. The pregnancy thing notwithstanding. So that's my lecture for today about that. We saw all of those. The prolapsed uterus is very common, particularly in women with multiple pregnancies. The pelvic floor is not much more than some muscles. There's a couple of openings in them. I mean, you have the anogenital openings, the anal, urinary, and genital openings. In the female, there's a whole area. If you did not know, there's a whole division service at McGee Women's Hospital that does pelvic floor surgeries. My mother-in-law, who died recently, in her 80s, had a pelvic floor reconstruction there, because what happens is that weakness and that prolapse Then it's not so much incontinence as it is, significant leakage from a urinary perspective and a number of urinary tract infections, which had her having some hospitalizations. My mom had that done when she was about 67. So it had to do, and typically associated with multiple pregnancies and other risk factors that are there. So that's a good unit over at McGee here. We have a wonderful hospital for that. My daughter delivered at McGee when she was low these many years, it was going to be 23 and a half years ago. So moving on, the big player here is the endometrium when we talk about really the functional aspects, the physiological aspects. Not the endometrium, not the myometrium, it's just a big muscle enclosure. It's the endometrium. The endometrium is this unique layer that has two strata. It has something called a base layer, stratum basalis, which is always there, and the stratum functionalis, which develops every month and which is shed during pregnancy. So the whole idea of the basalis always there, and every month it forms a new functionalis. If we have implantation, successful fertilization and implantation, the functionalis is there and eventually becomes a source of nourishment, forms a placenta, et cetera, and is all part of the normal pregnancy process. In the absence of implantation or successful implantation, there at that point it sheds, and that's what we call menstruation. We're going to look at the cycles that are involved with it. So it's a unique layer, the functionalis, that provides not only a spot for implantation, but nutrition. You're going to see that the egg, once it's fertilized, has about 6 to 7 days worth of nutrients from the mother cell. All of the cytoplasm and the organelles come from the mom. It's there. The male deposit, that's where we have mitochondrial DNA, and that's where we can look at the mother's DNA as opposed to not. It's a Friday. Couldn't people leave me alone with business stuff until the weekend? So here's the functionalis and the basalis. The basalis doesn't respond to hormones. We're going to get into which hormones the functionalis responds to. That's really the subject of today, is to look at the two cycles, the ovarian cycle and the menstrual cycle, and see how they come together and what is causing what part of what, so to speak. This is a mature functionalis. Here's the very thick muscle. Here's the base layer, which stays the same. When you start to see these large glandular structures that are there, thinking like that, that's going to be a source of, again, nutrients and appropriate preparations or protection for the implanted fertilized egg, wherever it implants. So that's important. The blood supply. The ovaries have the gonadal arteries. There's even a little branch here. But these come off the internal iliacs. You remember from lab, you have the aorta. The aorta bifurcates at the end in what are called common iliacs. The external iliacs go to the lower extremity. The internal iliacs, they go into the pelvic cavity. That's where and the uterine, the key to this is, they go to the uterus, they arch. That's what arcuate arteries are over it, surrounding this sort of hollow, I hate to say bag, but receptacle-like enclosure. And then they radiate into the endometrium. They point to it. What's interesting about that particular radiating artery perspective is that you have straight arteries that go to the basalis, but the unique feature are these spiral arteries. The spiral arteries are the ones that supply the functionalis. What happens after ovulation, what causes that functionalis to develop and mature and be receptive, is principally progesterone. It comes from what's left of the enclosure for the egg. The egg ovulates out. The enclosure, which is called the follicle, and that follicle takes over the job of the ovaries at this point and basically secretes a combination of estrogen and progesterone, mostly progesterone at that phase. It will do that for 10 days. At the end of 10 days, if there's implantation, Okay, at that point, if it's implants into the uterus gets sends a chemical signal to the ovaries and to this structure called the corpus luteum, which is doing all the work. It says, hey, we have implantation. You need to stay doing this for roughly the next 3 months. Because by that time, we will build a placenta and the placenta will take off. That chemical is very famous. It's called HCG, human chorionic gonadotropin. That is a substance that comes in such large levels and is so easily detectable. It is where the EPT or early pregnancy test comes from. That's extraordinarily reliable. I mean, we're talking, 90, orders of 99% reliability. So that very easy. You go to we used to be the dollar, now it's $1.50 tree. Get one of those. Why couldn't it just be the dollar tree? Then it was $1.25 tree. Now it's $1. It's like Five Below. Now it's 10 below. Soon it'll be 15 below. Need a lot of money from Five Below on Squishmallow. Oh, good old days. Nevertheless, here they are. These are the spiral arteries. So what happens? In the absence of implantation, this enclosure, which has become what's called the corpus luteum or yellow body, starts to basically stop working. It starts to shrink and basically dies. It becomes something called the corpus albicans, white body. There's alba for white, but effectively it just deteriorates and kind of like a little internal scar and then goes away. What it does while it's making the progesterone, these arterioles are fine. What happens when the progesterone ceases, they kink and spasm. So the blood supply of the functionalis ceases. And what happens, whenever there's not enough blood supply to anything, it begins, that layer here, the interface dies. And they start to separate. And it fills with some tissue fluid. Back at the ranch, in the meantime, in the arterioles, they're building up a pressure head. I mean, the blood's still trying to push out of them, but they're in spasm. Once that spasm releases, now that increased blood flow, that backed up blood that needs to come out, pushes the whole functionalis and causes it to shed, along with the tissue fluid. So it's mostly, when we think of what menstrual fluid is, it's not all blood. There's some blood in it, but it's tissue, and it's tissue fluid, and it's some blood. There's comparatively little blood, which surprises people. I say it again and again. A thimbleful of blood will make a gallon of water turn red. Don't need a lot of blood. A lot of hemoglobin in blood. The red stuff. Nothing here anatomically, nothing here, nothing here. That to me is anatomy, and more anatomy. Okay. Note for the mammary glands, which I think is important. Okay, the mammary glands, which, first of all, when we talk about breasts, they're mostly fatty tissue, not glands. The glands really don't enlarge and don't become productive. They're a modified sweat gland, which we call an apocrine gland, which we had talked about a little bit in anatomy and physiology. The tail of that mammary gland, so to speak, and the tail of that breast structure goes into the axilla, which is filled with lymph nodes. That's why when there's a lump in the breast and a suggestion that it could be cancerous, you always do a lymph node dissection. It metastasizes there. That's really, a lot of times, they'll look at the lump and say, well, it's not clear, but they always have to wait for the lymph nodes to come. That's the normal course. One thing we know about, that's where anatomy plays an important role in knowing how things spread and where they're likely to spread. Because we know anatomically we know if I have skin cancer here, I know I'm going to have to look either in the axilla or around the elbow. If it's coming from the foot, I want to look behind the knee or in the groin. We know where anatomical structure is up here, the nodes are here. So all of that's part of it. Yes. So these only the glands themselves become functional pregnancy and lactation. So, and you can take a look at this type of stuff. Again, the size of the breast is more fat related than anything else, and it varies. It's horrible. I mean, the number is probably higher than that these days. I mean, it is more common than prostate cancer. So it's even more, there's even a greater incidence of this than in prostate cancer in the male. So both of those are very sad. They're glandular cancers. So all they're what we call adenocarcinomas. That glandular cancers are a major source. When you hear about people having a very short lifespan after life expectancy after a pancreatic cancer, that's a glandular cancer. Watch out for this. Okay, so these are different risk factors, and it's interesting. Pregnancies, first grade, no shorter periods of breastfeeding, all of those types of things. Okay, but this is the interesting note: 70% of women with breast cancer have no known risk factors. So the fact that it may not be in your family or you don't have those risk factors doesn't preclude someone from getting it. We know the importance of these two genes, and they're the ones that you have to check, and they will always be checked because of the extraordinary risk you have of developing both breast cancer and ovarian cancer. That's why we hear famous people and everyday people electing to have double mastectomies because the likelihood of cancer is so high, and then further electing whether or not to have reconstruction or not. So I used to tell the anecdote about had 5 children, my first cousin's wife, 5 kids, and after the 5 kids, she had lost her mom and an aunt, 2 sisters, to breast cancer. So there was a strong tendency. It turns out she had both genes. Thankfully, she had 5 healthy kids. But after that, very, very slender, runner, and she liked to have the double mastectomy and the reconstruction. I don't know what was the underlying factor, but one reconstruction was fine. The other one was a nightmare. I mean, she had went through so many surgeries. And I haven't seen her in a number of years, but when we saw her, it was at my mom's funeral many years ago. She was doing quite a bit better. I was very happy to see that. So, I mean, it's not an easy road. So, and then mammography, and these are, I don't ask about this because this is older and the guidelines change. I don't know what they are today. I mean, my mom was so diligent about this because it was just arguably the thing that frightened her the most. Because back then, from her generation, the notion of having breast cancer was just the scariest thing possible. And that was, so many of her friends had gone through that, and she was so scared about it. Fortunately, she did not have anything that required any aggressive treatment whatsoever. And I'm not doing this part. To be very honest with you, it's give you a short course. Women are born with their eggs. That's why, unlike the sperm, which happen at puberty, it doesn't matter where they're ovulated into the peritoneal cavity. Your immune system knows them already. But they've been around since we started. It's about 450,000, roughly equally divided. That would be what's called precursor eggs. In meiosis, there are 2 phases: meiosis 1, meiosis 2. They are arrested. In other words, they're sitting in the ovaries before they start to develop in what's called prophase 1. Hardly anything have happened. Just that what I drawn on the board, that idea of synapses and genetic diversity, that's all that had happened by then. When they're ovulated, they stop. They've completed first meiotic division, and they're arrested in metaphase 2. They have yet to complete meiosis. So they're still immature eggs in that sense that are there. They don't, unless they're fertilized, they don't complete meiosis. Fertilization is the trigger to complete meiosis and allow the fertilization to proceed and basically create the combination of the male and the female component, the 2 haploid cells becoming diploid and forming what's called a zygote. So I'm just giving you that as background. So there's effectively of these sort of a number of these each cycle are readied even before the cycle starts, but really only one, maybe sometimes more than one, if we're dealing with a potential for multiple births, is selected to become what we call the primary follicle or the primary oocyte that's going to develop into the egg. So, I mean, they're just summarizing that here. Here's the secondary oocytes, so this is after ovulation, and it's only completed if fertilization occurs. These granulosa cells surround this. The follicle is what's left and becomes this corpus luteum, this yellow body that takes over after ovulation for the role of the ovary of producing estrogen and progesterone, principally progesterone. And so the primordial follicles are the earliest ones, and they go through all of this. But only one, and occasionally, but not that frequently, more than one is selected as the primary follicle. That's what's going to be ovulated. And that primary follicle, effectively, when it's ready to be ovulated, by that time it forms what we call a tertiary or vesicular or antral follicle. You will see it in this. That means there's enough fluid that surrounds it that it's going to create a push on a weakened ovarian wall that's going to allow ovulation to occur. What's the trigger for ovulation? A giant surge of luteinizing hormone. We call it the luteal surge, a big spike in LH production, which you will see shortly. So here's what it looks like. Here's that vesicular antral phase. This is ovulation. The egg and some surrounding structure, supporting structures are ovulated out. Again, not completed with meiosis. The remnant, the follicle, what's called thecal cells, you don't have to know, they become that corpus luteum. Here's the yellow color, taking over the progesterone and estrogen production. And effectively, these are what's happening. And so until there's fertilization, okay, arrested in metaphase 2, if it is fertilized, then it will proceed on to complete meiosis. Still, it's just amazing how this process occurs. It shocks me. It always amazes me how some people get pregnant so easily and some cannot. So follicles have two fates. Okay, they're either going to not survive, and 99.9 of them are never even get started. Okay, only a selected few of primary are activated, and this is where the FSH comes in, and one is the dominant follicle, and that's all you really have to know about that. Again, the secondary one, once it's ovulated out, 6 to 7 day journey, it has enough cytoplasm to nourish it for that, and if it doesn't implant, then it's just going to die, so to speak. It will never continue to undergo, because even during its journey, it's starting to undergo mitosis now and form like a little ball of cells that eventually are ready. In this class, we don't do that. Did you have growth and development? Did they go over some of the stuff, endoderm and ectoderm and mesoderm? Is that ringing a bell? Growth and development? Yes, no? You'll get there. I promise you, you'll get there. I always think that's a fascinating course. Nothing really special here. Again, with women, they're there from the beginning. With men, the difference with women, you have only the childbearing years. In men, obviously, it starts at puberty and continues on effectively through the duration. I'm not worried about these phases. Okay, and again, this is that becoming a primary follicle, why and how. Because again, it takes about a year for it to be ready, and then the primary one is effectively the one that's selected. And this is that's that vesicular or antrum, that vesicle or antrum that facilitates the actual event of ovulation. It pushes, you can see it's pushing on the wall. The wall weakens because of the chemicals that are about, the hormones, bless you, and then we have ovulation. And then the enclosure, as you see, comes that corpus luteum. Not much I have to see there with this. I'm going through these because I know there's nothing on it. Nothing on it. Same illustrator. They're just going through the details. In the last, whatever we have left, the last roughly 15 minutes, this is everything. There are two cycles, the ovarian cycle, and it's only in the ovarian cycle where there's a little bit of variation. The variation is in the follicular phase. As you can see, it's a limited number statistically. More than 80% of women do not have a predictable 28-day cycle I know a lot of women are more like clockwork, things like that. My wife with ovarian dysfunction, my first wife, there was never anything close to that, but indeed it occurred. She was prematurely, yeah, yeah, prematurely menopausal. So this phase maybe typically could be 13 or 12 days. There's a lot of variation. Not the luteal phase, 14 days, because that corpus luteum works for 10 days, and then it stops, unless there's been implantation, and in that case, again, it will go until the placenta up to 3 months. So that's a distinct 14-day period, because even after 10 days, then you'll have the 4 days, which will end at the start of the next cycle, which is the start of menstruation, you'll see shortly. So the one dominant follicle, sometimes there's more than one. That's where you can start to look at multiple births, and they comment on that as well. This is what happens. Ovulation is accompanied by that luteal surge, and what accompanies that is the German, they called it, maybe the term is Milchschmerz, is this, some women feel, not all. When we were doing infertility, we did basal body temperatures, and they didn't have digital thermometry abundantly then. They had, it was the old, they had a little, you had to read it, but this is a very specific one that had small increments, and you plotted it out on graph paper. And if there was a spike, typically at a mid-cycle, that's when someone was ovulating, and that's when you would try to get pregnant. So that's what we did, albeit unsuccessfully, but that's standard procedure back then. This is 45 years ago. So as you can see, there's a small percentage, but that definitely occurs. And then the corpus luteum secretes progesterone primarily and some estrogen, and the whole progesterone is going to maintain the, how should I say it, that stratum functionalis that's there. In the absence, it scars or involutes or shrinks, okay, after the 10th day, and erodes, and then at that point the endometrium begins to erode, and at that point we have the onset of menstruation. So it takes a while. It's adequate fat levels. This is a big deal. Women, this is the way little girls in figure skating and in gymnastics are kept as little girls. They intentionally prevent the onset of puberty because it takes away from their performance. Don't think it doesn't happen. It happens all the time. My daughter's a competitive figure skater for 7 years. There was a girl here, this is a long time ago. It was 30 years ago. And this girl was a national champion at the 2 lower junior levels. Her parents intentionally were keeping her out of puberty. Scary. I mean, I not to her doing. She never became anybody famous or recognizable name. I have no idea why we lost contact. But to me, the only way I can think of parents, or we see this with athletes too, even from certain countries, China, doing this type of stuff. They select, why they're so good in diving and gymnastics, they select them body type, flexibility, and then keep them skinny as possible. Period. End of sentence. The word that comes to mind is evil. So again, leptin levels are based on fat. They're so important. And when we have people who are intentionally dieting and crash dieting, they can throw themselves out of these cycles and have real significant problems. So I don't want to go over all of that from there, because we basically covered the same ground before with the ARG, the GnRH, the FSH, and the LH, and then rather than just testosterone, in the male we have estrogen and progesterone. So the whole thing is that surge stimulates all the other events that are there. Local vascular permeability, in other words, there's more blood flow to the area, inflammatory response, enzymatic changes, and effectively ovulation ensues. Shortly after that, estrogen levels go down. The LH transfers it into the corpus luteum. It secretes mainly progesterone, but some estrogen. Progesterone keeps the functionalis functional. for implantation and maintains the pregnancy if it occurs. So I'll show you what the phases are. So we want to look at the comparison between the menstrual cycle, and I'll get back to show it. First, I'll show you the ovarian cycle. So here's the ovarian phases. So it starts here. Even as menstruation has begun, at that point, because the corpus luteum is no longer producing estrogen and progesterone, that arc got active. The lowness of progesterone and estrogen in the bloodstream has triggered that GnRH to release follicle-stimulating hormone and luteinizing hormone, and we start the process all over again. The follicles are stimulated. We pick out a dominant follicle. It matures. As you will see, there's a luteal surge that triggers the ovulation with the events I just described, and then the corpus luteum will take over and manufacture the mostly progesterone and some estrogen. Again, the start of the uterine phase, it's sort of like the preparation for menstruation is the end of the ovarian phase, and then effectively menstruation is the start of a whole new cycle, and typically 4 or 5 days. And at that point, what happens is, after menstruation, we start a whole new functionalis proliferates, gets ready, and the secretory phase, it expands, it secretes all the necessary materials to facilitate the implantation and eventually the nourishment and the development of the fertilized egg. So I'll back up a little bit here and show you. So first phase is menstrual, and then before ovulation, we call it proliferation. This is again. And so the ovulatory phase, different. I'll show you the names that are there. The first one, it's just getting started. Basically, menstruation means this was the functionalis detaching and menstruation occurs. By that 5th day, already now, the new follicles are starting to grow and to produce estrogen of their own. Those levels create the new functionalis, creates more glands, like we saw in that micrograph and in that illustration. The spiral arteries increase. All of those things occur. We're even developing that mucus plug to prevent, because by this time, assuming that was the goal, assuming at this time the egg would have been fertilized and we don't want it to come back out. So ovulation occurs at the end of that proliferative phase. And then this is the one that's most consistent in duration. Okay, that secretory phase, the endometrium is ready. This is all about progesterone levels. It begins to secrete, the glands enlarge, the plug becomes firmer. Okay, if fertilization does not occur, that corpus luteum deteriorates. The spiral arteries, what happens again, they kink. And because of that spasm, it allows that interface to die. And then when they relax, that rush of blood pushes everything out and we start over again. And so we're going to stack these diagrams. And this is the whole ball game. One slide. So normally when it comes to FSH and LH from the pituitary, so they stay at a relatively constant level. It's only for ovulation that we get that remarkable luteal surge of LH and a little mini spike of FSH. That's what accomplishes. Other than that, it's a relatively constant level throughout, either causing the eggs to develop, grow, and mature, and then afterwards making sure that there's really no unusual changes and that the corpus luteum is going to continue to function. So they really don't play a major role afterwards that are there. So again, we have the follicular phase, ovulation, and the luteal phase. So remember those names. For the menstrual cycle, we'll get down at the bottom, but you can see what's active. Here, estrogens predominate, not massively so, in this phase, in the follicular phase, or in as you can see there, in the proliferative phase of the menstrual cycle. Not so much progesterone, but after ovulation, it's all about the progesterone. That's what's taking that secretory phase to the new level. Really, the glands have started for them. Here, they really enlarge and get ready for it. So you can see the relationship. That, just understanding those levels is all you have to do. Bad dieting, loss of that fatty layer, all of those things, very, very significant problems. That lack of leptin can shut down reproductive cycle. Every author I've read agrees 5 to 15% body fat is normal for reproductive function. I mean, that's where when you see, just answer problems with folks who have eating disorders, whether it's anorexia or bulimia, all the things. It's sad. I realize it's a complex problem. And so all the bad things that occur, because the whole idea of what estrogen does, it's not just the ovary, okay? It's not just keeping the reproductive tract happy. It's not just secondary sexual characteristics and all the things that we're familiar with. It's this. It limits the normal levels of this, limit the likelihood of cardiovascular disease, because they keep your cholesterol down and the so-called good cholesterol, the high density lipoproteins, which are a sign of health, that you want to keep high, they're desirable, keep them high with exercise and physical activity, where they're supposed to be. Calcium, and that's because the absolute postmenopausal women are so worried about osteoporosis. It establishes the cycle. It ensures normal pregnancy. All of these types of things. It's so vital. Think of what happens with what we see the hallmarks of menopausal women. We have potential osteoporosis. We have increased likelihoods of cardiovascular disease. All of those things come into play. All the hot flashes, the hormonal imbalances, and some are worse than others. So it covers all of these. There's nothing to the sexual response, the same as the male. Very, very easy. Just read through it. The only difference here is that here there's none of that refractory period. You have multiple climaxes, and certainly they're not necessary for conception. This is the part I'm going to dictate and send to you on sexually transmitted. You already have it done. It's the same basic talk I gave to my advanced. There's not the same detail I do for my microbes. And that's it. We're good. Thank you. So we'll see you exam time. And if you need me, I'm here Monday. Email anytime, of course.